webinar series. We host about 6 webinars a year, so please watch for invitations from us in the future, or you can visit our website at priorityconsult.com to find a list of upcoming events. Today's webinar, Playing Moneyball in the OR, Using the Right Data Analytics to Reduce Spine Costs, is the first in a 3-part series on containing spine implant costs for hospitals. We believe that this is a really timely topic and hope that you're able to leave today's webinar with new information and ideas about the steps you need to take to reduce costs for your hospital. Our speaker today is Joseph A. Jackson, Managing Director with Strategic Healthcare Services. Joe is going to tell you a little bit more about Strategic Healthcare Services during his presentation. But before we get started, I want to take a moment to invite you all to mark your calendars for the 2nd annual Priority Consult Workshop. The workshop is scheduled for September 25th and 26th this year in Indianapolis, Indiana. And we will be offering a day and a half of presentations dedicated to spine care and the spine industry, including more from Joe Jackson, today's speaker. Registration will open in July, and I hope you'll plan on joining us. Okay, with that, I thank you for joining us today, and I'm going to pass things over to Joe.
Okay, thank you, Rachel. Good afternoon, everybody. Thanks for joining us for today's webinar. Again, playing Moneyball in the OR, making sure you use the right data analytics to reduce spine costs. My name's Joe Jackson, and I'm a Managing Director with Strategic Healthcare Services. Before we begin, I'd like to discuss some rules of the road for the webinar. The topic of lowering costs is on everybody's mind, so we certainly encourage you to ask questions during the course of the webinar. However, in an effort to be respectful of everyone's time, we'd like to move through the core material as efficiently as we can. We expect to get through the material in about 25 to 30 minutes. So if you do have a question, please utilize the electronic controls that are associated with GoToWebinar. And what you guys should see is a gray control panel on the right side of your screen. And at the bottom of that control panel, you should see a dialog box. You can type a question in the dialog box, click send, and it'll alert one of our organizers that you have a question. We'll be sure to facilitate an answer to all of your questions either during the webinar or after the webinar via email. So if you guys are able to follow these rules of the road, it's going to ensure a productive and efficient call for everybody. So thanks in advance for your cooperation. All right, here's our agenda for today. First, what I'll do is provide everybody a brief introduction to the company and tell the group about me. Next, we'll discuss the state of the industry, specifically the explosive growth and demand for physician-preferred items, or PPI, which would include spine implants. We'll talk about the variability of PPI costs among hospitals and the challenges hospitals are currently facing in terms of decreasing reimbursement and increasing costs. Next, we'll review what Moneyball is and how you can leverage the concepts of Moneyball to take advantage of these concepts in your OR. In short, Moneyball begins and ends with data. We'll review which data points matter, where you can find them, and the persuasive power and building of strong analytics. Next, we'll provide you guys with a case study, and what that's going to do is cement the concepts of Moneyball we're going to discuss today. And the case study will list some specific steps and ideas that you can take to quickly and effectively reduce spine costs in your OR. We'll drill down into concepts like data management and enrichment, product price benchmarking, and building strong, robust analytics. We'll explore how and why these tactics are effective. Lastly, we'll close with Q&A and discussion. Okay, about the company, Strategic Healthcare Services, or SHS for short. We're a management consulting firm, and we have a specific focus and expertise in partnering with our hospital clients in identifying, managing, and continuously reducing PPI costs. We focus on spine, joints, trauma, and cardiovascular devices. About me, again, my name's Joe Jackson, Managing Director at SHS. I have over 16 years of healthcare experience. I've worked in various operational, financial, and supply chain roles. 10 of those years were spent working as a Director of Supply Chain, later on as the Executive Director of Orthopedic and Spine Services. That was at a 600-bed acute care health system in Atlanta. I've got firsthand experiences with the unique challenges that hospitals face and in developing creative solutions to help solve those challenges. On the bottom half of the page, you guys should see my contact information. Please feel free to call or email me with any questions that you have, or if you would like a copy of the webinar slides. Alternatively, if you need a copy of the webinar slides, you can also get them from Priority Consult. And you can send them an email at, the email address is education@priorityconsult.com. Again, that's education@priorityconsult.com. Send them an email, and you can get a copy of the webinar slides, or if you have an additional question. Okay, the state of the industry. Why is this important? Why do we care? For most hospitals, with the exception of labor, medical supplies are the largest expenditure in the budget. The pie chart on this slide shows how a typical hospital's medical supply spend breaks out. So PPI makes up the largest segment of the pie and it's continuing to grow. So implantable devices, which would include spine devices, they make up the vast majority of the PPI spend in this the PPI spend segment. So effective management of the PPI utilization and spend can save hospitals millions of dollars over a few years or even annually, depending on how big you are. As I mentioned on the previous slide, demand for these procedures involving PPI are growing in number and complexity. For example, Pew Research estimates that 10,000 people per day turn 65. This statistics represents the top end of the baby boomers moving into this age bracket. So given that, we would expect that trend to hold for the next 15 to 20 years. People who are 65 and older are the chief consumers of healthcare in our country, especially for joints, cardiac, and spine. In fact, spine demand starts earlier in 65, which would create even more demand for that particular service. So as this demand has grown and will continue to grow, the availability and complexity of these devices has grown with it. An estimated 10 million PPI-related parts are purchased by U.S. hospitals every year. A single manufacturer's item master can contain over 20,000 parts with literally millions of construct combinations. So the number of patients, PPI parts, construct combinations, and the technological differences present a mind-boggling challenge to hospitals. In fact, this challenge at times can just be plain overwhelming. So if you consider all that, what's the end result for U.S. hospitals? There's a huge variance in the price paid for the exact same implant across U.S. hospitals. So not similar implants, the exact same implant, part number to part number. There are two recent studies that address that particular topic. One was the Government Accountability Office conducted a study in 2012, and it indicated that in the stent and CRM categories, their pricing varied by as much as 46% in the marketplace. So let me be clear, not comparing stent to CRM, but stent 123 to stent 123 in different hospitals, the pricing varied by as much as 46%. A New York Times study in 2013 indicated that hip, knee, and spine pricing varied by as much as 42%. Now, let's take a step back. Some of those variances are certainly due to volume commitments. For example, the 10-facility health system doing thousands of spine procedures per year is going to get a deeper discount as compared to the single-site community hospital doing just a few hundred. That's fair and reasonable, and all of us should set our expectations that not all of us are going to be able to get the Mayo Clinic price. However, the purchasing pattern doesn't explain that level of variability. There's a bigger reason, and in fact, an exponentially bigger reason that that level of variance exists in the market is due to hospitals not having clear PPI utilization and cost data from which to work. If you don't have good data, you won't have persuasive analytics. If you don't have persuasive analytics, you'll be going into your next negotiation with one hand tied behind your back. Last section on the state of the industry. Hospitals are faced today with decreasing revenue and increasing costs. Moody's put out a report late last year. It was their 2014 nonprofit hospital outlook report, and frankly, the outlook was fairly grim. Hospital revenue growth is declining. Medicare has reduced reimbursements by 2%. Medicare has also reduced their disproportionate share base payment by 75%. Medicaid is reducing their payments by $1.1 billion, that's with a B, over the next 2 years. And commercial and managed care insurance rates are not increasing, or they're increasing far below their normal rates. So add all that up, everyone, there is no new revenue. There's no additional money, I should say, flowing into the revenue side for hospitals. In fact, it's going in the opposite direction. It's going down. To compound things, that same Moody's report had indicated that expenses at not-for-profit hospitals have outpaced revenue for 2 consecutive years. So again, you have the trend lines for both revenue and expenses going in the wrong direction for U.S. hospitals, at least according to this Moody's report over the next couple of years. So to take a step back, margins were already slim for PPI and spine-related procedures with Medicare and Medicaid as the payer. So having steep reductions from these payer sources makes preserving a positive margin on these cases exponentially more difficult. So hospitals need to take measures to be able to manage their PPI costs as responsibly as possible and protect those PPI margins. And that's why we're all here today, is we want to be able to take action, instigate positive, lasting financial changes at your facilities through the Moneyball concepts and the case study we're about to cover in the webinar. Okay, playing Moneyball in the OR. Again, Moneyball at its core is a data-driven exercise. So what we're going to talk about is what are the data points that matter, where can you find them, and how to build the persuasive analytics that you're going to need to accomplish your goals. What we'll do before we get too far down the road, let's make sure we're all on the same page of what the concepts are for Moneyball and what Moneyball is. And again, I mentioned before, at its core, it's a data-driven exercise. So what Moneyball says is organizations must use deep empirical data to manage their financial resources. You can't trust what you see, hear, or what your gut tells you. Emotions and group thinking will cloud your judgment. The difference between great versus poor financial performance, and this is especially true in hospitals, is razor thin. In fact, it's so thin you won't notice it with the naked eye on a daily, weekly, or monthly basis. You need data. You need good, deep, robust data to make the most informed decisions that you possibly can. Okay, now that we are all on the same page of what Moneyball is, let's get into what are the data points that matter. What are you looking for? The data you gather and analyze, it must be precise and specific. You need to know what specific parts and constructs that you're using, at what unit cost, on what types of patients, by which surgeons, by which procedure type, how many levels are being fused, and by how many cases. Again, you can't rely on what you hear is happening or what you think might be happening. No matter how type of ship you run, you're going to find usage and costs in that data that surprise you. That's guaranteed. The question is, how surprised are you going to be? Let's talk about the non-critical data points. Now, the information I have in that section under non-critical data points, they're certainly important measurements, but they're used for a different purpose of what we're discussing today. Those data points, they're too generic and high level to really craft a pointed plan. For example, GL data, the amount of implant spend, whether you have it broken down by just spine, orthopedic, or all implantables in general, on the general ledger, it's important. It's important at your month-end financial meeting to measure actual versus budget. The total case counts, that's needed to measure your OR room utilization. Allocated supply costs, say, coming from decision support, that's needed to measure your surgeon contribution margin. Again, these data points absolutely have value in running a hospital, the ones that I have indexed under the non-critical data points. But for our purposes, to really hone in on reducing spine costs, they're directional at best in indicating that you might have a problem. That's all it tells you. You need to mine and compile the data points that matter to craft a targeted and effective cost reduction plan. Okay, so we know what the data points we're looking for. Where can we find them? The good news is they do exist somewhere in your hospital. The bad news is they're probably spread across various systems and repositories like your MMIS or purchasing system, your surgical information system, or even in a filing cabinet for the paper sticker sheet or implant lock. So walking back, a big barrier to success, or a big problem, I should say, is the lack of IT data integration in most hospitals. So as a consequence, pulling all the data points that matter electronically for most hospitals is really hard to do. So if all else fails, you can always turn to the sticker sheet. And let's take a step back and make sure we're on the same page of what the sticker sheet is, or how I refer to the sticker sheet. For every implantable case, like a spine case that happens in your OR, it's going to be supported by all likelihood by a rep from that company, a representative that'll support the case inside the OR. For every implantable device that the physician uses on the patient, there will literally be a sticker that comes off of that product and goes onto a paper requisition sheet. So 5 implants used during the spine case, you'll have 5 stickers on the requisition sheet. 10 implants used, 10 stickers, etc. And that sticker will have the pertinent information, like the part number, the price, the description, etc. What the rep will do at the conclusion of the case is have everything that was used on that patient with that doctor on that requisition sheet in the form of stickers. Takes that, gives it to an OR buyer. They'll produce a purchase order based off of that sticker sheet. So while using the sticker sheet is a low-tech method, certainly, it's extremely effective. The sticker sheet is a treasure trove of information related to implantable usage, pricing, the procedure type, and the name of the surgeon, among many other valuable data elements. Okay, analytics. Number one, benchmarking is a must. You've got to know what the market is bearing for specific parts and constructs your hospital is using. When attempting to enlist a surgeon's support or when engaging a device manufacturer, you don't want the discounts you're asking for to appear to be arbitrary in any way. That's why you need the benchmark. You'll need hard data supporting the reductions you are seeking. Next, you'll want to establish a goal price. There are many different price points to pull into a benchmarking analysis: a low price, an average price, a mode price, a high price, whatever have you. You'll need to consider your hospital's specific variables, what's happening on the ground, like your size and location, to really start honing in to what is going to be a fair price. You'll need to weigh and consider all those things when going into a goal price. You want it to be fair and reasonable, but also to save you money. Again, all of us would love to have the price that the Mayo Clinic is paying, but we're not all the Mayo Clinic. We don't have that type of purchasing volume, so you want to hone in to what's fair and reasonable depending on the situation on at your hospital. So once you establish a goal price, you can compare your actual price and begin building the savings analytics. You'll want to do it by surgeon, by procedure, by part type. You'll really want to hone in on which doctors is this going to impact, on which procedures, by which part, and which manufacturers. Again, a very, very targeted plan. Next, scatter graphs. These are very, very powerful and compelling tools to use, and they can be simple or very robust. But again, we would recommend that you use these because, again, they are very, very powerful. Just like you see on the graphic on the bottom of this particular page, you'll have a vertical axis measuring the dollars and a horizontal axis measuring the number of benchmark price points. It's kind of hard to see on the PowerPoint here, but each one on that blue line, each that is made up of a series of dots, and those dots represent a price point that another hospital is paying for a particular construct that your hospital might be using. Again, I'll get into more how we can use this during the case study, but again, scatter graphs, very important, very effective. Okay, the case study. The hospital profile. We want to take some of the concepts that we've already walked through and be able to cement them with some really good ideas that you can use that have been used during this hospital's case study that you can take back to your facility. So the profile for this particular hospital is located in the Midwest. The spine spend was over $16 million annually, had 46,000 individual parts purchased during the course of the year, and over a dozen spine surgeons were involved. So again, big practice, lots of moving parts. And the cost reduction steps that were followed by this particular organization were what we had laid out earlier in the presentation. Data management and enrichment, price benchmarking, and building strong analytics. Okay, to give you a little bit of background, like most hospitals, this hospital did not have a clean, consolidated report on spine usage and costs available. Just didn't exist. It had to be created. Fragments of the data, again, like most hospitals, it existed in several different locations. Some of it was in the purchasing system. Some of it was in the surgery system. Others were on the paper implant log. Again, they had the problem of we couldn't tie it together electronically to be able to run a report and pull it all out. The data points that matter, that we've talked about, again, they existed, but that level of specificity needed to be mined from these various sources and compiled. So what you see on your screen here is an example or one of their implant logs that's been sanitized. So as I said, it's low tech, but it is a treasure trove of information. And the decision was made, so let's go back to the very lowest common denominator till we know we can see what was used on which patient, by which doctor, at which prices. Going to this document, everybody, eliminates all the statistical noise that'll occur in a general ledger account or cost account or whatever it might be. You can really hone in on what is going on here. Now, of course, you can't do much with that from an analytical perspective. You got to take it and enter it into a database and make it digital so you can start doing some analysis. So on this next page, this was the end product. Again, sanitized, but I think it will give you a very good idea of what was done. You're going to want to do it by case. So you'll have your case number or your patient account number. Say it would be a good way to divide it up. You're a surgeon, the item, the part number, the manufacturer, etc. The quantity, unit costs. And again, all those relevant data points, or quote, the data points that matter, get it into a database so you can have it clean and consolidated, and then you can start doing some analytics. And get it into this type of format, very, very important first step. So what's the net result of that? You know, after you do that, you can start doing some meaningful analysis. And in this case study, you know, the product utilization and cost trends, they jump right off the page at you. You'll be able to see right away what are the most commonly used parts and constructs. So you can really zero in on, kind of get bang for your buck. Where do we need to focus? Cost disparities across vendors for similar items. Are we paying one vendor more than another for a very similar item? Physician comparisons on implant cost per case. Do we notice that one doctor costs us more money than another? And it also gives you a place to look. Why does that happen? Implant cost per case by procedure type. Do we notice that some procedures cost us more than others? If so, why? Again, it'll really start honing in on what the plan's going to be. Implant price benchmarking. Again, for this case study, as it is with all hospitals, this is a critical step in the cost reduction effort. One, it's going to indicate what the market is bearing for the product. Two, it's going to provide a tangible and defensible target when you go into negotiations or talk to a physician. In this case, the products were benchmarked individually, not on a procedure basis. And these items were benchmarked against 500 plus hospitals and 1 million parts. So this is a very modular process with this case study, and I would highly recommend that you have to mine the data, compile the data, get it nice and clean. Next piece is we got to look at the individual parts. So again, this is sanitized, but it's going to give you an idea of what you can do. That top line, that poly screw, the very top line, you can see they used 215 of those at a price of $1,650. So in that highlighted column, the targeted item price, many different price points come into the benchmarking process like I alluded to before. You're going to have many things to consider. What's the lowest price you find? What's the average price you find? What's the mode price you find, etc. So you'll have different price points to consider across many different hospitals. But again, you have to take in consideration the different variables, like this case study did, on what is going to be the most appropriate target price for you, considering, what's our purchasing volume, how big are we, and are we able to move volume commitments, whatever the case may be. But I guarantee you guys that by going through this exercise, even without moving things, you can be able to save money to drive down to a fair price, a better price of what you're paying now, even by going through this low-hanging fruit type of exercise. So, again, thinking through this in a modular fashion, you built the first step with you've mined and compiled the data. You've looked and benchmarked the prices of all the individual prices paid. So now you have a before and after snapshot of here's our target price inside of our usage and costs, and then here's our actual price, and you can start being able to see where the opportunity lies. And in this case, you'll want to know which surgeons do we need to talk to. Again, they're called physician-preferred items for a reason. There can be some political sensitivity around these items. So by doing it this way, you're going to see exactly, it's going to jump right off of the page at you, which doctors do we need to talk to, and for which vendors is he using, for which parts, etc. So you can really start thoughtfully crafting the plan that you want to use to be able to accomplish your goals. Again, looking through and being able to talk to your physician in a very informed, reasonable manner, and not going there with any ambiguity or not looking like you're cherry-picking a price. Again, it's hard data. Very, very important, not only to achieve your goals, but also to strengthen relationships with the physician. So it doesn't look like, again, you're just trying to arbitrarily get to a price. This particular slide shows the scatter graphs. And again, this is what the end result was for this particular case study. On the top graph represents the cost per case for a single-level lumbar fusion for this particular hospital. The bottom graph represents a two-level lumbar fusion, again, cost per case. The vertical axis is your prices. The horizontal axis is the number of price points. And that blue line that you see running through the graph, what that is signifies, they're all little dots. I know it's hard to see on the PowerPoint, but every dot represents a price point that another hospital is paying for the exact same construct combination that was being used at this case study hospital. So where they were was that red line, the current costs, or the current case costs. And those vertical black lines that you see represent the percentiles. So when they looked at this, they saw, wow, we're in the 75th percentile in terms of price. While we may not be the biggest name brand to command the best prices out there, we certainly should be better in their mind than the 75th percentile. They decided the 25th percentile for single-level lumbar fusions would be a reasonable and fair place to go. And that's what the blue line represents. So again, you can see by calling it out in this direction, it's a very powerful analytical tool to use, and it really jumps off the page at you of what you're using, what you're driving towards, why you're driving towards it. And again, that's going to get your physicians to listen, gain their trust, and frankly, it's going to make your negotiations go that much more smoothly when if you're giving your manufacturers, here's what we're looking for and here's why. It's all out there in the bright sunshine. And again, this way that creates more of a dialogue, more positive dialogue with your implant manufacturing companies. So again, very, very compelling analytical tool to use is scatter graph. Now, the whole thrust of this PowerPoint today, or this webinar today, was talking about data and Moneyball. And again, extremely important, guys. You can't get to the best price that you can find or the most fair price that you can find without it. You got to have it. But a mistake a lot of hospitals make is that they feel like that the work is done the day they sign the contract with the implant manufacturer. And I'd be remiss if I didn't bring this up in today's webinar. Don't do that. PPI is notoriously difficult to manage. Physicians are fickle. They change their mind very, very quickly. And the OR is a very open and porous place. So things do and can change. So you need to have a plan in place for what happens to convert every dollar that you have projected in, say, spine savings and convert it into actual savings by the end of the year. It's not like a med surge item where you can kind of just let it run on a par level, on a par cart. These very fluid, very porous areas, the OR, so you have to manage it very, very tightly and not turn your back on it. So what this is here is the management plan that this particular case study hospital put into place. On the bottom half of the graphic is the say what we had done in the first quarter or everything we had talked about today in that call-out box. But everything against that track utilization and managed savings line continuum, that represents, the various steps that they were going to put into place to manage the implant costs and utilizations in conjunction with the device manufacturer and with the physician to make sure that, again, everything that was projected in savings turned into actual savings. You can't turn your back on it, and this is a high-level plan that they used. So to close out this particular case study, it's very important. It's a two-pronged process. Again, we focused a lot today on the data. Very important. The price control requires the data intensiveness that we've been talking about, but it's just as important as the continuous utilization management. Again, ensuring every dollar gets converted from projected to actual savings. And a good way you can think about it in terms of managing utilization and the difference between pricing controls and utilization management. Again, a good way to think about it is using an iceberg analogy. If you picture an iceberg floating in the water, you could see most of the iceberg, or a little bit of the iceberg, is above the water line. And that's the price controls and the data exercise that we've been talking about it. You can see it, you can touch it, and it's tangible. But below the water line, you see this huge mass of the iceberg that, unless you're underwater, you can't see. So it's very, very important that above the water line is price, below the water line is utilization. So that's the piece that can wreck your cost reduction plan, is that stuff, that activity that happens below the water line. So you have to make sure that you're very cognizant of what's going in, how you're going to monitor that progress after you've signed the contracts with the device manufacturers. It's been very often that the clients that we've worked with have said, gosh, we had a great plan in place a couple of years ago. We stuck our head up, and we just didn't get to the dollars that we thought we were going to get to. It's very fluid, lots of moving parts. So, again, unchecked utilization shifts will erode savings. You got to monitor it very closely. Again, I'd be remiss if I didn't at least touch on that in this particular topic today. Okay, we've gotten through the core material. Thank you for joining us. I'm going to check the dialog box to see if we have any questions. And again, feel free to email us directly if there are questions. I've got one here I think would be applicable to the group. What have you found within the hospital, or what role, in the hospital is best to drive these initiatives? They seem very labor intensive. And again, they are, guys. And that's a fair question. The pieces that I laid out, again, you can't push a button, and you certainly can't just ask somebody for it and expect to have it turned around in an hour. It is labor intensive. And that is a fair statement, but it's worth every penny. I would say that certainly your director of supply chain, your director of OR should lead the effort. What I would also say is that person should be making decisions. They shouldn't be the person spending time in the trenches with the data. Somebody else needs to do that. And again, I understand labor is tight, but it's that important that either you rebalance someone's role, or that's part of their role, or you look outside the organization, whether you hire somebody, you get a third party involved, whatever your cost structure will allow. I think considering all the various changes that are coming in healthcare, this issue needs to be addressed to where, you've got the reimbursement line going down, both from public and private payers. So tight management's important. In my mind, it's worth putting the eyes on this. Again, I can't speak to a specific hospital, but I can say it's worth putting a specific FTE or looking outside the organization or whatever have you to have do it. Okay, I'll wait to see if there's any additional questions. Here's another one. Let's see here. It has to do, how have you found, are manufacturers willing to work with hospitals in partnerships? These relationships are typically combative. Yeah, and that is true. And I think, guys, I think the gist of that question, I think a lot of these questions come in shorthand, guys, so bear with me. But my interpretation of the question is that, are there positive ways you can partner with your manufacturer when doing these types of deals? And there is. In our experience, looking for give and take relationships is very, very positive. Meaning, if you're able to say, okay, manufacturer A, if you give us a 10% reduction because our data supports it on total joints, let's look at areas of hospitals where you currently don't have a big market share, say like trauma, to use a simple example, and have them bid on trauma, give them access to trauma. Now, of course, you can't drive up costs in trauma, but I think if they can provide in that particular example, if they could provide products that are just as good at a more discounted rate, then you get into a win-win type of scenario. You further push down costs while a manufacturer has the chance to make up market share. I think there are creative ways to do it. It takes some trust and it takes a good relationship, but I think that's a very, very important way or important tool in the toolbox to be able to pull out, to be able to make sure that we're all hitting these goals and playing well in the sandbox together. I think that's very important. I think the days of pounding our fists on the table and shouting each other over the negotiating table are numbered. I think there has to be a lot more cooperation. So I think there are chances for us to work together in creative arrangements out there to be had. Okay, anything else? I'll give it another minute, see if another question pops through. Okay. Well, again, thanks, guys, for spending your afternoon with us today. We really do appreciate it. Hope you took some value away from some of the ideas and concepts that we presented, and I really do appreciate your time. Rachel, is there anything from the Priority Consult side that you would like to add?
No, just want to thank everybody for joining, and watch your email inboxes for the second webinar in the series. You'll be receiving invitations shortly for that.
Great. Thank you, Rachel. Thanks,
all right,
everyone.
Thanks a lot, Joe. That was great.
Okay, bye-bye.
Okay, bye-bye.